Vestibular Migraine, Evidence-Based Updates to Management Guidelines. And Dr. Laskhan works for Navaloka Hospitals PLC.
Head and neck surgeon for Navaloka Hospital, Colombo. 2007, he did his MS in ENT. In 2010, he was awarded the diploma from Royal College of Surgeons, London. FRCS he achieved in November 2012, and so I would request Dr. Lakshan to take over the session and continue with his topic on management of vestibular migraine and its management guidelines.
Thank you very
much.
much.
Yes, I'll stop sharing.
For your kind words of introduction, and it's a very timely topic, and I like to thank you for choosing this topic for discussion on today's panel. So without further ado, let's move on to the slides. We have only half an hour to discuss this topic, so I'll keep it very simple. I hope you can see my screen clearly and hear me. Am I audible?
Yes.
Akshay, you okay?
Yes, sir, you're audible.
Okay, right, okay. So we know about migraine. Migraine is a very common problem, and some of us already may be having some experience of having this condition ourselves. And when we practice as clinicians, we see migraine or migraine, variously pronounced, the same thing, very commonly. It's a very disabling disease, as you know, severely compromising education, professional outcomes, and economic burden to country as well because of the huge healthcare costs. And we also know about vertigo. Which is an illusion of movement, where things really spin around. It may be the object that is moving around, or maybe the surrounding, or some form of illusion of movement is called vertigo. And it comes under umbrella term of disequilibrium, where other forms of disequilibrium such as gait abnormalities, incoordination, syncope, pre-syncope, everything is lumped together. But it's vertigo where an illusion is involved is most likely to be due to inner ear dysfunction. So these two conditions have been fairly known for a long time, and with time, there had been a merger of these two symptoms together. People have started noticing a connection between migraine and vertigo. So that has interested many people, whether this is a part of migraine, the vertigo symptoms, or it could be a different symptom altogether. So a diagnosis of vestibular migraine or migrainous vertigo, or variously named in such combination, is important for three reasons. First of all, this diagnosis is often missed. It is a missed diagnosis. And also, it's a diagnosis sometimes underdiagnosed. So sometimes you diagnose it wrongly, sometimes you don't diagnose it at all. And it's a mismanaged diagnosis. The management of vestibular migraine is entirely different to day-to-day vertigo. So it's a diagnosis that is not properly diagnosed, underdiagnosed, and it's mismanaged. So therefore, it's important that we know about this condition. Secondly, the morbidity. As you all know, migraineurs seems to have higher neurotic symptoms like depression, anxiety, and other psychological morbidity. The less you diagnose this condition, the less you properly manage this condition, the chances of morbidity to the society, to that particular patient, is higher. So that's a huge burden to the function of that patient because it's not been properly managed. Thirdly, chronicity. So if you really don't diagnose this condition properly and don't manage it properly, the condition, the vertiginous conditions, can become chronic, and it's difficult for people to treat after that. So because of a couple of reasons like this, mainly these and some more, it's important for you to know about vestibular migraine and diagnose it properly. There had been a proliferation of the literature on this subject, especially recently. So this 2017 article in Current Treatment Opinion, 2019 in BMJ, and 2021 this year there have been review articles on this subject. So when preparing for this topic, which is the evidence-based update, I used those references, including 16 others. And at the end, I will show these references. If anyone is interested, you can get your hands on it and read it out. So the outline of my talk, first I'll discuss how this diagnostic label came into being, how it was evolved. Then I will discuss about current criteria, what is accepted as the criteria for diagnosis. Then I will discuss few theories, the latest theories about how this is being brought about. What is the pathophysiology? Next, I will move on to diagnosis, which is the most important part, I think, out of the entire thing, and the management based on that diagnosis. So first of all, diagnostic entity. Now, when you go to history of vestibular migraine, it dates back to 131 AD and I think 1873, there's another mention, but more important thing is in 2001, when this Neuhauser and colleagues, I hope I pronounced the name proper, German group, came up with diagnostic criteria for the first time. What they did was an interesting study. They had 200 disease clinic patients, 200 migraine patients, and 200 orthopedic clinic patients. And then they followed up, they have analyzed these patients' symptoms, and then they came up with these diagnostic criteria for the diagnosis of vestibular migraine. So I think one of the key things here are the fact that there should be 5 episodes and there should be present or history of migraine and one or more migraine features with at least 50% of the time of this vestibular episode. It could be headache with features like one-sided unilaterality, pulsating, moderate severity, aggravation by routine physical activity. Those are the 4 characteristics of headache of migraine. Photophobia and phonophobia, visual aura, any one of them. And it should be not explained by another vestibular disorder. These are like primitive sort of diagnostic criteria informing this diagnostic entity. And it is actually formularized by this international classification of headache disorders, beta 3 version, where they define definite vestibular migraine and probable vestibular migraine. Definite and probable. Here in definite vestibular migraine, if we take, there should be at least 5 episodes fulfilling these 2, which I'll come to in a bit. 5 episodes. The key term is 5. And then the current or past history of migraine with or without aura, that's B. C and D, the vestibular symptoms of 5 minutes to 72 hours. Now, when we discuss vertigo, we always discuss about various things. We discuss about whether these are episodic or continuous to start with. So when you take episodes, we discuss about episode duration. And then we discuss about less than a minute vertigos, hours vertigos. If we take less than 1 minute, BPPV, that is the commonest one. I think Daminda did an excellent lecture and explained everything about BPPV. So now we are moving to a little longer, 5 minutes to 72 hours. That is the sort of duration that we are talking about when it comes to vestibular migraine sort of headaches. So that's a vestibular symptom duration. Lastly, at least at 50% of these vertigo episodes, one should have these headaches, just like in Neuhauser classification, unilateral, pulsating, moderate severe intensity, aggravated by routine physical activity, photo and phonophobia, visual aura. Well, actually, if you really come to think of it, this is actually important for research settings for you to clearly diagnose vestibular migraine and do studies upon it. But if you really think in your clinical practice, you have vertigo on one hand, you have headache on one other hand. The headache has various features. Severity, it has to be severe or moderately severe. It has to be associated with photophobia, phonophobia. Thirdly, visual aura. This headache has several characteristics. One I already mentioned, it's severity. And it also has unilaterality. It has pulsating nature, and it's worse by movement. 4. So connecting those couple of things happening 50% of the time, we are thinking most probably vestibular migraine. So next chapter is about pathophysiology. Now people are wondering how this migraine or migraine and vestibular migraine, what is the pathophysiology? What exactly is going on in the brain? There have been 3 theories. The first one is the longest lasting one, Trigemino Vascular theory. That was the first one to be proposed. Now, a recent theory is about sensory modulation. Thirdly, although we know there's a strong family history, we didn't know which genes were involved. Now, there is certain genes, certain alleles which are responsible for migraine. These have been identified. So a little bit of introduction, not going into details about these theories. In trigeminal vascular theory, what is proposed is the trigeminal nerve stimulation has connection to dural blood vessels. So if you look at this picture, you can see the dural blood vessels here. And these are the trigeminal neuronal connections. When for whatever reason these neuronal connections are hyperstimulated, you get a sterile inflammation. It's a sterile inflammation. It's not infective. It's a sterile inflammation, which causes blood vessels to dilate. So that cortical depression and dilatation, aura followed by headache. So that is one of the theories. The second theory is about brain areas now, superior colliculus, prefrontal motor cortex, parietal lobe, certain areas, temporal lobe, certain areas. They have identified as key zones where various sensory modulations converge into. These are called convergent zones. Convergence zones. So if there are issues with convergent zones, there can be migrainous episodes, especially vestibular migraine. So the vestibular symptoms, vestibular impulses come into certain set of neurons. They are converging with trigeminal and other neuronal inputs. So that's a second theory, which is a later theory. The third theory is about genetic. The chromosome that they're talking about is chromosome 20 to 22, and there are other alleles as well. Next chapter is about clinical features. Now, history is the key to diagnosis of these conditions. As you have already seen in these characteristic classifications in IC International Classification of Headache Disorders, I told you already about headache, that it's unilateral, mostly. It can be bilateral as well in non-classical variants, but I'm talking about classical common garden migraine. Throbbing, visual symptoms, eye pains, various oscillopsias and scintillating changes in the visual fields. Aura, family history, nausea, vomiting, phonophobia, photophobia. These are common things that we clearly see in the conditions of headaches, are characteristics of headaches. Of that. But there are other things also. For example, allodynia. Allodynia is when you get a gentle, usually harmless sort of a touch, sometimes may be painful. You have probably seen migrainous patients sometimes come in with certain areas being hypersensitive, allodynia. Osmophobia, strong sense sometimes may be difficult for these patients. So those are the features of headaches, some characteristic that might guide you. When it comes to vertigo, it can be object motion, motion intolerance, and positional vertigo symptoms also are common with migrainous. And there are other important discriminatory symptoms. This is important. If you take motion sickness, there is a study where they have analyzed all the patients with vestibular migraine according to the diagnostic criteria and found out at least 50% will have motion sickness. So that's another feature. If your patient is having motion sickness, you can suspect, in addition to other features, could be a vestibular migraine patient. What about vestibular march? Vestibular march is a condition in pediatric population. In pediatric patients, sometimes you get a condition called benign paroxysmal torticollis of childhood. Benign paroxysmal torticollis of childhood, where you get episodes of head movements to a side. After a while, the patient becomes okay. There are no other neurological signs, no other neurological symptoms. They may be pale, they may be sweating, but neuroimaging, all other features are normal. They grow out of it. This move on to BPVC, benign paroxysmal vertigo of childhood. And this will move on to vestibular migraine. This is called vestibular march, and that has been clearly documented. There's another feature that you can get, and the other feature you can get is ID migraine. Now, when you diagnose migraine, I've already discussed about history points, and in other countries, they have questionnaires. In fact, questionnaires have been validated to diagnose these conditions with high degree of accuracy. But questionnaires are time consuming and we don't have time to go through all these questions. A very interesting study has come up with 3 questions that can be useful in diagnosis of migraine. One is severity of headache. It has to be moderate or severe. Second thing is nausea and vomiting. Third thing is photophobia or phonophobia. If you have these 3, sensitivity is more than 75%, closer to 80% of diagnosing migraine. Lastly, triggers. If the patient has known triggers, maybe lack of sleep triggered it, maybe going in sunlight triggered it, maybe stress triggered it, or non-triggers, if they are present, another feature of vestibular migraine. So I think out of all these slides, if you get this slide into your head, I think our achievement is a great achievement. Our objective of this lecture is fulfilled if you get this slide into your head, because this is a history that diagnosed this condition. Okay, so let's move on to examine. Usually it's normal. It's usually normal, but there are positive Rombergs. There may be positional vertigo as well. But as Daminda mentioned, there are various characteristics of BPPV positional vertigo. There is latency, there is decrescendo, crescendo, decrescendo, there's adaptability and all. But in positional vertigo of vestibular migraine, there's no latency. There's no latency. And it's a mild version. It's not very severe. And it's horizontal, and sometimes it can be vertical as well. It doesn't fatigue away. So it's a very mild form of positional, especially during acute episodes. There are red flags as well. So when you examine possible vestibular migraine patients, if there are these features, you need to be careful that you may be discussing, you may be dealing with someone else. Like, for example, skew deviation. When you do cover test, uncover test, there is an alignment, not vestibular migraine. Direction change in vertical nystagmus, not your common vestibular migraine. Long track signs, hard neurological signs, not your routine vestibular migraine. So these are red flags. If you have this, think of neuroimaging and ruling out other. But anyway, so it's a neuroimaging may be necessary in most patients, because you have to diagnose and exclude other conditions for you to diagnose vestibular migraine, if you can remember the last criteria. So differential diagnosis, huge list is there, but BPPV is one of the commonest one. We've already discussed about changes in positional vertigo that you get with BPPV as opposed to vestibular migraine. You know about Meniere's disease, there are characteristic changes, for example, hearing loss, tinnitus, oral fullness that you might not get in vestibular migraine. And vestibular transient ischemic episodes where you can get other posterior circulation symptoms like diplopia, dysarthria, and things like that. So that's your differential diagnosis. Investigations are of only little value. It's not very important, but there are changes in these parameters people have noticed in loudness, discomfort levels, ABR latencies, vestibular evoke myogenic potential, especially O vestibular ocular, which shows utricle and changes in the vestibular area, caloric changes, radiology, and other causes excluded. More importantly, the key message is the history-based diagnosis. Last chapter on management. Trigger management is very important if we can identify triggers and rule out. And I think one of the things that our chairperson wanted to convey is about hormonal contraceptives that may be triggers. And also we know about loud sounds, endocrine changes, loud noises, even stress, environmental changes. These conditions can give rise to, as triggers, lack of sleep and things like that. So if you, when it comes to management, you can try and rule out these triggers. There are nutraceuticals also being proposed as first line sort of management, like magnesium in a dose of 400 to 600 milligrams daily, with a common side effect of diarrhea. Riboflavin of 400 milligrams, again, orange urine. Coenzyme Q, insomnia dyspepsia. Butterbur is a plant-based thing. So there are weak evidence, as you can see on the side in 2018 and 17. Some studies have done on this, but they are not common practice in management of vestibular migraine. Lifestyle changes. The American Migraine Association has come up with this mnemonic: SEEDS. S stands for sleep. So a proper sleep deprivation should be avoided. Eat regular meals, exercise, diet, avoiding certain components of that, which I'll come back to in a minute. Stress management. So SEEDS is a mnemonic proposed by American Migraine Association, Migraine Foundation, for remember in the comment. The key thing is migraine thrives on inconsistency. Inconsistency. So if your sleep, if your diet, if you exercise, if your routine is consistent, that helps. But in today's day and age, asking for consistency in lifestyle may be difficult. Anyway, so another mnemonic is 3 C's that diet-wise you can try to avoid: caffeine, excessive caffeine, chocolate, cheese, especially aged cheese, may be triggers for certain patients. So try to moderate on those. And the last mnemonic is FFO, fresh food only. Again, I ask, what they say is if you can shop on the periphery of supermarkets, you're likely to get fresh foods. It's in the center and the daily corner that you're likely to get processed food. So fresh food only diet also helps. So these are all lifestyle changes. Now, after that, you can have a patient who has acute severe vestibular migraine, where the treatment is pretty much similar to migraine episodes. There are studies to see whether the migraine treatment is equivalent for vestibular migraine patients. They have only shown moderate evidence only. I could find only one randomized control prospective study in pharmacological treatment, that is on beta blockers on prevention, which I'll come to when we do the prevention. On acute management, the 3 important things are painkillers, antiemetics, and triptans. So there's Brufen, paracetamol, diclofenac, sumatriptan, amitriptan, solmitriptan, domperidone, cinnarizine, beta-histine, diamine hydronate. But out of those 2, painkillers, antiemetics, and triptans have been shown to be effective. Preventive treatment for those who have very disabling recurrent vestibular migraines. The cutoff of recurrent is 15 episodes per month. Then we can think of prophylactic treatment. These are the categories, the broad categories of medications. We have beta blockers, we have tricyclic antidepressants, we have serotonin, norepinephrine receptor inhibitors, calcium channel blockers, anti-epileptics that can be used in preventive medicine. And these beta blockers, there's a study on metoprolol, They have followed up on randomized control studies, and in fact, it was discontinued halfway because it was found to be ineffective. So that particular study didn't show a benefit on beta blockers, but propranolol has a very good support in evidence in the management of prevention of vestibular migraine. Second important drug in prevention of management is amitriptyline or nortriptyline. The third is venlafaxine. These medications have been shown to be effective in prevention. So if you look at the basic side effects, propranolol, fatigue, hypotension, impotence, metoprolol about fatigue, hypotension, impotence, being a beta blocker again. Topiramate, important thing is paresthesia. Flunarizine, weight gain, sedation. Amitriptyline again, sedation, dry mouth. A lot of people complain of that, and they can get urinary retention as well. They have discussed other forms of treatment like vestibular rehabilitation therapy in vestibular migraine. This is the latest study in 2018 about it, and it only showed moderate, statistically insignificant benefit only. So I think with that, we have covered the history of this diagnostic condition and how the clinical features have evolved and how the diagnostic criteria has come about. How would you diagnose it? How would you treat it? How about the prognosis? In a study where they have followed up these patients for 9 years, have found 90% of them are still symptomatic. Not a very good job. But the good news is 56% of them have reduced frequency of symptoms. I think partly this is because these diagnoses are being made clearly only recently, and the newer medications and newer treatment protocols are only being introduced recently, and emphasis on lifestyle changes and non-pharmacological managements are being introduced only recently, especially although the migraines have been in the domain of neurologists. Now more and more ear, nose, throat doctors are taking over of some of these management strategies, particularly because you need time for these patients to discuss and input on which vertigo management is also important. And there are paradigm shifts in management of these patient conditions. So I hope with time, this prognosis will become more brighter in the future. Thank you very much.